So it all started in 2016. In 2016, a brand new therapy was developed and FDA approved to treat a type of cancer called B cell cancers. B cells are a type of white blood cell. These were patients who were failing every other therapy, and patients were going into remission, which was phenomenal. This was a therapy where the patient's own T cells were used to attack and kill their B cells. Well, let's then jump ahead just a few years later. In 2019, in China, there was this woman who had failed all the therapies for her B cell cancer. So they gave her this CAR T cell therapy. But it just so happened that she also had severe systemic lupus for 20 years. So they gave her this compound CAR T cell therapy. Now, many of you have already heard about the CAR T therapy on social media and stuff. And that was related to most of us have heard about a group of patients in Germany. Well, this is China. In China, they used a combination called BCMA and CD19. These are all letters that I'll explain later on in my talk. Well, the German group, they only use the CD19, so this is a little bit different. But they gave her this therapy, and a month later, her systemic lupus erythematosus was completely in remission. They were even able to stop her medications. All of her autoantibodies became negative, like anti-nuclear antibody, anti-double-stranded DNA antibody, and they were just astounded. And so they thought that they were resetting the immune system. Everybody thinks it started in Germany, but no, the first patient was in China, 2019. Well, very soon after that, they treated another patient also with lymphoma. They gave it to her because of the lymphoma, but the systemic lupus went into remission. Well, being astounded, they went ahead and planned to treat 11 more lupus patients who had severe systemic lupus, and all of them had lupus nephritis as well, where it was attacking the kidneys. And later on, we'll hear how those patients did. Well, in 2021, April in Germany, an Asian woman, just 20 years old, had severe systemic lupus. It was attacking her heart, her valves, the lining of her heart called the pericardium. She had severe lupus nephritis, horrible arthritis, and also cutaneous lupus with a rash. Her lupus nephritis was so severe that she was dumping over 2,000 milligrams or 2 grams of protein in her urine per day. It's called proteinuria. And just to give you an example, normally we should have less than 200. So hers was over 10 times what it should be. Her C3 level was low. Her anti-double-stranded DNA level was high. All of these are bad things. She had failed all therapies, to include chemotherapy with cyclophosphamide. Well, we can also figure out how severe someone's disease is by looking at something called the SLEDAI. SLEDAI stands for Systemic Lupus Erythematosus Disease Activity Index, and we count up the points and we can tell how severe it is. Hers was 16. All you have to do is be above 10 to be severe, so you can get an idea of how horribly severe her lupus was. Well, the German group, they had realized that there was a mouse lupus model where they gave this CAR T therapy, and they were putting these mice into remission. So they decided to give this woman CAR T therapy. They used a different one though that just noticed CD19. A month after treatment, her lupus was in remission. Audience, we have never seen a therapy like that before. A lupus patient with such severe lupus go into complete remission in a month. That was just phenomenal. Well, Dr. George Shett, he was the leading researcher and rheumatologist who treated this young woman. He gave us a nice demonstration during the American College of Rheumatology meeting just this past November, and he showed us her photograph. And this is not her, by the way. I got this off the internet, but it just reminds me of how happy she looked after she was treated. Well, up to this point, up until November of 2023, when we look at all the medical literature, there have been a total of 24 systemic lupus patients treated with CAR T therapy. All of them had severe systemic lupus, like the patient I just showed you in the earlier one. 22 of those 24 are completely in drug-free remission. That means they're taking no treatments whatsoever, no steroids, no cyclophosphamide, no methotrexate, no hydroxychloroquine. Two of the patients were close to remission. The only reason they weren't in remission is that one of them was 1 month after treatment, one of them was 2 months. So it was just too early to tell. So, what in the heck is this CAR T therapy? That's why we're here this morning. My name is Dr. Donald Thomas, and I'm a rheumatologist that I practice in Greenbelt, Maryland. And my specialty is treating patients with systemic lupus, erythematosus, and also other autoimmune diseases such as Sjogren's disease. And one of my passions is encouraging and helping patients learn how to take care of themselves better and to live with lupus better. And so I'm glad that I'm here today to be able to talk to you about this exciting therapy called CAR T therapy. But what the heck is it? Well, let's break it down. The C stands for chimeric. The A and the R stands for antigen receptor. That's a whole thing by itself, antigen receptor. And then it's all a T cell. So it's a chimeric antigen receptor T cell. And we're going to look at each of these different components and put them all together. When you put them all together, this is what it looks like. This is a CAR T cell. So it is a T cell. The antigen receptor is that black thing that you see right there. And we all talk about antibodies like anti-nuclear antibody, anti-DNA antibody. Well, those are antigen receptors. Anti-DNA, it notices an antigen called DNA and it can receives it, or it's a receptor and receives it. So this is also an antigen receptor, similar to an antibody, but its molecular structure is just a little bit different. And then it's chimeric. And what the heck is chimeric? It comes from a Greek monster called the chimera. The chimera was, he had the body of, I'm sorry, the head of a lion, the body and the head of a goat, and then the tail was a snake. It's basically an organism that's made up of more than one organism put together. And we do have those in nature, by the way. So this is a chimera. It's made up of several different organisms put together. The T cell comes actually from the patient. We get the T cells from the patient, take them out, engineer them, and make them into these CAR T cells. And then we have a virus put in DNA that's not actually part of the human DNA, and it actually ends up making it and wrapping itself inside of the DNA. And then that DNA that's introduced into that cell produces that antigen receptor that you see. And then it's chimeric because it's made up of all of those different parts. So this is the CAR T cell, and it's chimeric because it's made up of a human T cell, but also the viral infected DNA, and that makes this antigen receptor. So it's an engineered type of cell. And how do we give it to patients? Well, we have the patient first. We drain out their blood. We do something called apheresis. Apheresis takes out the blood of the patient, but then it separates them into those white blood cells, like you see the sac there that's in yellow, and it separates the red blood cells, and it puts the red blood cells back into the patient. Well, those white blood cells are taken to the laboratory, and then the T cells are removed, and they're taken to the lab, and they're kept alive. But they just have the T cells all by themselves, which is a type of white blood cell called a lymphocyte, and it's related to B cells, but it's a little bit different. And then they take these viruses called the lentivirus. Lentiviruses, by the way, exist in nature, and lentiviruses are deadly to humans. What they do is they infect our cells. They attach to especially the T cells. They love to attach to T cells, and then they put their DNA into our own cells, forcing our cells to produce them and replicate them. They destroy that T cell, and then they go out, and all those different new viral particles go throughout our body and attack and kill other cells. But these lentiviruses are different. They take out their dangerous DNA that they normally have, and the engineers, they stick in a DNA to use it to cause cells to make things that we want them to produce and make. And in this case, we wanted to make an antigen receptor. So that DNA that you see, that blue spiral in the center of that purple virus, that's a DNA that's programmed to make an antigen receptor. And we can make it any type of antigen receptor that we want, to recognize B cells, to recognize T cells, and so forth. And then that lentivirus, remember I said that in nature, they love to attack our T cells. Same thing here. They recognize a T cell, those T cells that come from the patient, and then they attach to it. And then they end up putting their DNA inside of that T cell and inside of the nucleus. Inside of that nucleus is the patient's own DNA and RNA and other enzymes that help to make the proteins that we need to have inside of our body. But this particular DNA, it causes the cells to produce that antigen receptor. This is the CAR T cell. When that happens, we have a CAR T cell, that chimeric antigen receptor that is a T cell. And then in the laboratory, they replicate these so that there's a whole lot of them so they can put back into the patient. So this is that CAR T cell. Then we take the patient again, we go into the clinic, and then we give them chemotherapy. We actually give them cyclophosphamide and fludarabine, not real high doses, but enough that it decreases the number of white blood cells in their body, especially the T cells. And there's a reason for that, because we want to put these CAR T cells back into that patient and have them replicate and take the place of the patient's own T cells. So then after the patient has a low white blood cell count, they're infused back with those CAR T cells, like you see in this yellow bag right there, so that they can go into the patient's body. And then the CAR T cells, it notices that there's not very many T cells in the patient's body. And so we just naturally, the immune system wants to make sure there's enough T cells, and it mistakes these CAR T cells to be T cells that the patient should normally have. And then they replicate and multiply, and they go throughout all the tissues of the body. And then these particular CAR T cells, by the way, remember that antigen receptor, that black guy that's sticking out of there, this one is manufactured to recognize B cells, particularly a type of antigen called CD19. CD19 is a badge or an antigen that's found on B cells that lets these CAR T cells know that they are B cells. And when these CAR T cells come into contact with a B cell, the patient's own B cells, they interlock like a lock and key. This CAR T cell can only combine with a CD19. If it bumps up against a red blood cell that doesn't have CD19, it just ignores it. But it sees this B cell and it binds to it. They bind to each other, and then on the inside of the CAR T cell is a part of the antigen receptor that becomes active once they interlock like a lock and key, and that causes that T cell to know, or it thinks that the patient's B cell is a foreign invader, and it attacks that B cell and it destroys it. And that's the whole purpose. That's why they use it for B cell leukemias and lymphomas, is to attack those B cells and destroy them. And that's how they got into remission. Well, these CAR T cells destroy all of the B cells of the body that contain CD19, the ones that are in the lymph, in the blood, in the lymph nodes, in the joints that are attacking the lupus patient's joints as well. And all of those B cells, they disappear within a week after giving them the CD19 CAR T therapy. So you have to ask the question, why do we want to get rid of the B cells in the first place in our patients who have lupus? Well, it's important and it's helpful to know how the normal immune system works. If you know how the normal immune system works, then it makes it easier for you to understand what happens wrong in lupus patients. So our immune system, it's there to protect us. So like if we get infected with bacteria, and this is two different types of bacteria that you see here on the top, that looks like one called streptococcus, like strep throat. The one on the bottom looks similar to staphylococcus. You heard about people getting deadly skin disease from staph infections. And those little bumps that you see on those bacteria, those are called antigens, and they're distinctive for those particular bacteria. And for example, me, if I was a foreign invader inside of a giant, my antigen might be this little badge here on my jacket that says Donald Thomas, for example. And notice that, for example, the red bacteria, its antigen is round shaped. The one that's on the one on the bottom is square shaped. If they were to bump up into that CAR T cell that was triangular shaped, it would not recognize these. Each B cell or T cell only recognizes one particular type of antigen. So inside of our body, we have literally have trillions of B cells. B cells are also called lymphocytes, like you see on the left side of the screen. And each B cell only makes one type of antibody. Antibodies are a type of antigen receptor, just like I mentioned earlier. And for example, that B cell that you see on the top, or B lymphocyte, it makes that antibody that you see. And notice how the end of it is round, and it can attach to and recognize that antigen specifically for that streptococcal bacteria. And when it recognizes it, it multiplies. It knows that there's a foreign invader inside of our throat. It calls other white blood cells to the throat to make it safe and try to protect us. But the bottom B cell, it has a different shaped antibody that only recognizes that staphylococcus bacteria that we see down there. And so it activates the white blood cells of the body. This is a nice electron microscopy of a white blood cell that's actually attacking a streptococcus bacteria to keep us safe. It's going to actually engulf it and swallow it and destroy it. And during this process, this is what happens. So this is streptococcal infection of the throat. And this is what we see as doctors when we look inside of the throat. And it clearly shows the signs of inflammation that occur when the immune system becomes active. So, when the immune system becomes active like this, we see these problems such as the swelling. You notice how the tonsils are really swollen, almost touching in the middle. That white stuff that you see on them, that's the pus or purulence. That's actually the collections of white blood cells that are being drawn to the throat to kill that bacteria. Redness is another sign of inflammation. Pain, if anybody's ever had a strep throat, they remember how painful it is just to swallow. Fever because of the systemic inflammation, and horrible fatigue. Doesn't this all sound familiar? Because this also happens in lupus. It may not be as horribly inflammatory as this, but this goes on in the kidneys, the joints, the heart, the lungs, and it's different in different lupus patients. And by the way, this is why we as doctors, when you have a problem with your lupus, we want to get it 100% into remission. Even, and I say that because a lot of lupus patients, they might not feel so bad and they don't want to go up on their medicines, but we want to stop this 100% in the organs of the body. So now let's look at the lupus patient. Well, in the lupus patient, they have these bad B cells. We also call them autoreactive B cells, but I'll call them bad B cells. Autoreactive, auto means self, so these B cells react to the body itself, and they make antibodies that actually recognize the cells of our body and think that they're foreign. They think that they're foreign invaders. And just for an example, let's say that top antibody, and this is what it can do. When they attack the body, they can cause like this malar rash or butterfly rash in this young man who has systemic lupus. So let's say that top antibody is anti-nuclear antibody. The bottom one's anti-double-stranded DNA antibody. And then throughout our whole body, we have trillions of cells. All of these cells, except the red blood cells, have nucleuses inside of them. And just remember that anti-nuclear antibody and that anti-DNA antibody that we have inside of our body, they can recognize our own cells and think that they're foreign, attack our own body, and then cause the inflammation that we see of systemic lupus erythematosus. So just think about it. If we could come up with therapies that could destroy those bad B cells or those autoreactive B cells Couldn't we get rid of those horrible antibodies that are attacking the lupus patient's own body? And the answer is yes, because we're already doing that. Belimumab, which is Benlysta, and rituximab, which is Rituxim, are two very common medications that we use to treat lupus patients because they stop those bad B cells from making those bad antibodies that attack the person's body. But many lupus patients fail these B cell drugs, and there's a few reasons why that happens. For one thing, these are monoclonal antibodies or biologics, by the way, and they work primarily in the blood and in the lymph system, the actual flowing lymph between the cells of our body. But the problem is that they don't go into the tissues very well. It's the tissues that are being attacked, like the joints, the heart, the kidneys, and these medications like Benlysta and rituximab, they don't go into the lymph nodes very well or the joints. And we actually demonstrate, and we have actually demonstrated in research studies that even though a patient might be doing great and doing well with their lupus, they still have bad B cells or autoreactive B cells in the tissues. And this is one big reason why many patients do not respond to them. In addition, we have to keep giving these patients these medicines over and over again, because if you stop the rituximab or if you stop the Benlysta, those bad B cells are in the tissues, they start to multiply, then they go out into the bloodstream again to make the lupus more active. So it'd be nice to have something that's more permanent. And could we possibly cure lupus by just getting rid of all those bad B cells once and for all? And that's the theory behind CAR T cells, is getting rid of all of those bad B cells throughout the entire body. Well, everybody on social media, and a lot of you are here because of social media talking about this talk, there's been a lot of excitement on the internet because of 8 German patients who were reported on that received CD CAR T therapy. And see, remember, and again, these CAR T cells, they recognize just CD19 on B cells in the patient's body. And let's look what happened to those 8 patients. And so this was presented at our American College of Rheumatology meeting in just this November by Dr. George Schett. Each red dot that you see there is one of those individual lupus patients, and that's starting at its time 0 when they first get the CAR T infusion on the very left side, and then they watch them every 3 months after that. And this shows their levels of anti-double-stranded DNA. In about 70% of lupus patients, they'll have a high anti-double-stranded DNA level. And in most of those patients, that anti-double-stranded DNA level goes down when disease gets better, and they go up when the lupus becomes more active. By the way, that's not in everybody. Some of you have high anti-double-stranded DNA levels that never fluctuate, and they're just probably not really causing tissue damage, is probably one reason for that, because there's a lot of different anti-double-stranded DNAs. But these are very high levels. A level of 40 or higher is abnormal. And look at these patients. One of them had a level of close to 6,000, which is incredibly high, and it's usually associated with really severe systemic lupus. So they give them this CAR T therapy that recognizes CD19. And then at the 3-month mark, let's look what happens. At the 3-month mark, I got to click it here. All of these patients' anti-double-stranded DNA level went to 0. Every single one. Folks, I have never seen a therapy in my 30 years of practice ever cause 100% of patients' anti-double-stranded DNA level go to 0, and definitely not at the 3-month mark after starting therapy. That was just incredible. So next, I like to show you another part of a different thing that we can look at. And remember earlier I mentioned something called the SLEDAI score. SLEDAI is a research tool that we can use to look at disease activity. The SLEDAI scale you can see on the left side. Anything that's above 10 is severe disease activity. And look at these patients. Most of them had high disease activity. Several of them were very close to 10. And that patient that I mentioned earlier, hers was 16. So she's that red dot that you see just above the 15 mark. And what happened to these patients at the 3-month mark? At the 3-month mark, Every single one of those patients was in complete remission except for one. That one patient quickly went into remission after that 3-month mark, by the way. Folks, this is just crazy. We've never seen a therapy like this in our lives that can get this many 100% of lupus patients into remission. And not only that, their anti-double-stranded DNA, double-stranded DNA, single-stranded DNA went into remission. When I get a lupus patient into remission on a medicine like mycophenolate or methotrexate with hydroxychloroquine, we always need to use hydroxychloroquine. I just never see anti-Smith antibody become negative. It makes me realize that those B cells are disappearing. Interferon alpha disappears even. 80% of our patients with severe systemic lupus have high interferon alpha levels. That's a type of cytokine. Cytokines are the way that white blood cells talk to each other, and interferon causes the immune system to become more active. In fact, those of you who have heard of Safnello or anifrolumab, it works by decreasing or inhibiting how interferon works. It normalized. We just never saw that in 100% of patients, and 100% of the lupus nephritis went into remission. And not only that, but you have to remember all of these patients failed all of the standard therapies. And that's why this is such a why we're just all so excited about this possible therapy. Now, when we give them this therapy, we always are worried though, could we be causing bad things to happen by getting rid of these B cells? Because the normal B cells are important. For example, they're important for responding to vaccines and keeping us from getting infected with measles, mumps, a COVID infection, for example. But the interesting thing is, when they tested their levels for responses to the vaccines that they had already had in the past, they were still responding very well to those vaccines. A few of the patients got a new vaccination, by the way, after their CAR T therapy, and they had a good response. And the reason for that, by the way, is that the most mature type of B cell, called a plasma cell, they're not touched by the CD19, and they were still working and making those antibodies. So the B cell system was still working through the plasma cells, which is a mature B cell. So what happened to the B cells in these patients? Well, all of the B cells, 100% of them disappeared by day 19 after CAR T therapy, including those bad autoreactive B cells. And that's why the patients went into remission and all of their autoantibodies disappeared. Of course, we're worried, we need those B cells to fight off infections. And so they monitored them very closely. And fortunately, around the 100-day mark on average, the patient's B cells started to come back. But not only that, the German scientists, by the way, they were worried that these might be the bad B cells of the lupus coming back, but they tested them and they were not. These were healthy, normal B cells. So the patients, they were actually having their immune system reset. That's what the scientists and the doctors actually mentioned in their article when they demonstrated all this. So it was just really, really exciting. So we do have some unanswered questions from this study, though. And one of the questions that I have as a rheumatologist specializing in lupus and Sjogren's disease is that one patient was anti-SSA positive. SS stands for Sjogren's syndrome. 30% of lupus patients are positive for this, 70% of Sjogren's disease. Sjogren's disease is an autoimmune disease very closely related to lupus, and it primarily attacks the glands of the body, causing dryness, but it can attack all the organs, and it increases the risk of lymphoma, unfortunately, in those patients. Well, that patient, their anti-SSA antibody stayed positive throughout the entire study. That tells us that the CD19 doesn't destroy the B cells, all the B cells in this particular patient. So in my mind, in this patient, it did not reset the immune system. It did not normalize the immune system whatsoever, because that particular type of B cell was still alive. And so could CD19 CAR T cell be a wrong target for Sjogren's disease patient? That's just something I'm thinking about. And then 1 out of every 3 of our lupus patients are positive for anti-SSA. So could this be the wrong treatment for them? One of the things we need to figure out is what type of CAR T cell therapy, if it ends up being a good therapy, is best for each patient. We'll probably need to figure out their immune system beforehand, and that's something in the future that they'll certainly be working on, and they are doing that with some of the clinical trials that are currently designed. Now, it's very helpful to know how B cells mature. B cells actually, first, they're stem cells. You've heard of people getting stem cell transplantation for like leukemia and lymphoma. Those are in our bone marrow, and they actually start to make all the blood cells of our body, to include pre-B cells like you see up in the top left of this picture here, inside of the bone marrow. And that pre-B cell, it becomes an immature B cell. It goes out of the bone marrow into the blood to become a transitional B cell that can mature into follicular and M2 B cells. Then you have memory B cells, plasma cells, and then and plasmablasts, and then they can go back into the spleen, into the bone marrow as well, to stay active. And the question is, which of these are the most important to target in patients with autoimmune diseases? Because each of them have a little bit of different function. Each of them produce antibodies in different ways. And all of these have different badges. I talked about CD19 being a badge on white blood or on B cells, but each of these types have a combination of different badges, and we can make CAR T cells to target some of these and not the other ones. Now, just to point out a couple of these B cells, memory B cells are a type of mature B cell, but they're inactive most of the time. The B cells are just, these memory B cells are just sitting there. And let's say that a pneumococcal bacteria go into our body and it meets that B cell that actually can make antibodies against pneumococcal. It becomes active and recognizes it, makes those antibodies, and attacks the pneumococcus, and then it calls the white blood cells to attack all of the pneumococcal antibodies. So the memory B cells, and there's actually trillions of different memory B cells, by the way. That's just phenomenal to even think about. But that's how we're able to fight against so many different types of germs and cancer cells inside of our body. And then there's the plasma cells. Plasma cells are always active. They're just constantly churning out one type of antibody. So for example, a B cell that's responded to the pneumococcal vaccine or pneumonia vaccine, it's sitting there and just churning out pneumococcal antibodies on a constant basis, and it can produce 2,000 antibodies a second. Just think about that. In 10 seconds, 20,000 antibodies, and there's billions of these cells in our body. And also, these cells can be immortal, and that's the bad thing about lupus. Just think about it. If there's a plasma cell there that makes anti-double-stranded DNA that is constantly alive and never dies, we need a way to get rid of them, and this CAR T cell therapy is a possible way to do that. So all of these have different cell surface antigen markers, as I mentioned. And just for example, I mentioned CD19. That's what the 8 German patients received. Well, all of the B cells, from the pre-B cell to the memory B cell, they have CD19 on them, but the plasma cell does not. So when it destroyed all of the B cells in the body, there were probably still some plasma cells in the bone marrow, or maybe in the in the spleen, for example, that were still making antibodies, and that's why they were still responding to vaccines. But the question is this the right target for lupus patients or Sjogren's patients? CD19 is another marker. It also recognizes the same types of cells that the CD19 does. This, by the way, is what rituximab or Rituxan targets. It kills all of these, but it leaves those plasma cells alone. Now, remember the Chinese patient that I mentioned at the very beginning of the talk? She had a combination CAR T. It had both CD19 on it that kills all of these, but it also had one called BCMA. BCMA stands for B cell maturation antigen. BCMA is only found on the most mature B cells. It's found on plasma cells, on plasma blasts, and also on some of the most mature memory B cells as well. But it leaves all these other B cells alone. So just think about it. The Chinese patients, when they got BCMA and CD19, it killed all of these white blood cells or these B cells. So the question is that really going to be a better therapy than the other one that the German patients got? We don't know. We'll have to wait and see over time. Now, you might be scared and think, well, what's going to happen with all these B cells are gone? Well, remember, the normal B cells do come back after about 100 days, and that's because there's still live stem cells in all of the bone marrow that can then start to make new healthy B cells. So again, the question is which target's going to be the best in our lupus patients, and we really don't know. I mentioned the German group with CD19. The Chinese group is a combination of BCMA and CD19. There's one called Descartes-08, which is targeting BCMA by itself. I'm going to talk about that a few times in my talk because it's a very interesting type of CAR T cell therapy. Clinical trials are just now beginning in systemic lupus patients for this one, and it may be a good option, and I'll talk about why that is in just a little bit. So again, why do CAR T cells work better? Why do the CAR T cells work better than the B cell targeting drugs like Benlysta and Rituxan? It does have to do because Rituxan and Benlysta, again, they don't deplete all the tissue. They don't deplete the tissue B cells, only the ones that are floating around in the blood and the lymph system. While the CAR T cells, they go into all the tissues, because remember, we got rid of all the T cells with chemotherapy before the infusion, and so the CAR T cells, they think that they're normal T cells, and they recognize there's not enough T cells, and they start to multiply inside of the body, inside of the joints, the lymph nodes, the spleen, and etc., to destroy all of the B cells that are there, except the plasma cells with the CD19. So up to this point, remember I mentioned that 24 lupus patients have been described in the medical literature. I don't see this being recognized enough, by the way, on the internet. For some reason, they seem to just focus on the 8 German patients, but we have to remember the Chinese patients and also some other clinical trials that had just stopped, and it is a total of 24 patients, 22 drug-free remission. And by the way, 2 of them have been in drug-free remission now for close to 4 years, doing well without any medications. And that was 2 of the Chinese patients on the BCMA combined with the CD19. 2 additional patients are close to remission, and those 2 patients, by the way, got Novartis's CAR T cell therapy that targets CD19, and it's called YTB323. And those 2 patients, though, they were too early to tell if they're in remission because this takes about 3 months to work. But I suspect they probably are, but Novartis has not reported them yet. So we have to worry about potential side effects, don't we? Because we are messing around with the immune system. And the big one is the potential for infections. Reason for that is, just think about it. First, these patients got chemotherapy. They received a dose, just one dose of cyclophosphamide and one dose of fludarabine, and so that lowered their white blood cell count to include the T cells and the B cells. And then they were without any B cells for a total of about 90 days or so. And so that increases that risk of infection. But surprisingly, out of all of those 24 patients, there was no severe infection reported. One of the 13 Chinese patients had a urinary tract infection, but that's the only one that was reported. But I would like to mention something. Someone reached out to me in a personal communication on social media, and she told me that there was one patient who received the CAR T CD19 therapy in the German group, and that she did end up getting a severe infection and was in the intensive care unit. But we can't always believe what we hear from someone anonymously on social media. So I do have to say that. But this is also someone who's a scientist and who's very active in the lupus community. So, it certainly could be true. But I just want to mention that because it points out that severe infections are certainly a possibility. So it's not like it's a magic cure that's safe for everybody to get. There's also something called cytokine reactivation syndrome. Now, you remember during COVID-19 during the height of the pandemic would infect the body, then the immune system would become overactive and a lot of cytokines would be released. And we call it a cytokine storm. And these cytokines, like the interferon I mentioned earlier, would tell the immune system to attack the person's organs. And many people died of COVID-19 because of the cytokine storm or cytokine reactivation. Well, a similar thing happens in the patients with the B cell cancers. Some of the patients with B cell cancers, their cytokines would start to become overactive and their immune system would become overactive and attack their organs. And there were some patients who would die because of their CAR T cell therapy. Now, most of the time, these cytokine reactivation syndrome side effects were mild. They treated them with a medicine called Actemra or tocilizumab, like we do with our COVID-19 patients. And the vast majority did very well, but it is a problem in our B cell cancer patients. Interestingly, this has never been seen in any of the lupus patients. And we think, or any of the other autoimmune disease patients who have been treated, and we think it's because of the B cell load. The patients who were more likely to get the cytokine reactivation were those patients who had the highest number of B cell cancer load in their systems. And we think that's probably a big risk factor on why, and that may be why we're not seeing it yet in our cytokine in our patients who have autoimmune diseases, except a couple of them, and I'll show you that with one of the CAR T therapies. Also, these CAR T cell therapies can cause severe neurological side effects. We call it ICAMs for short. But in some patients, it actually attacks their brain, their spinal cord, and their nerves, and sometimes that can be deadly. They don't have a good idea on why some patients get this and some patients don't. It does seem to be partially related to a high B cell load, but that's not the full story with it. Fortunately, no severe neurological side effects occurred in any of the lupus patients, so that is reassuring. Now, there are three patients who were treated with Novartis's CD19 CAR T cell therapy called YTB323. It's a little bit different than the one that the German group did. This is one that uses newer technology. It's made faster than the other CAR T cell therapies, and Novartis was hoping that it would be actually safer in patients. But unfortunately, they gave it to 3 systemic lupus patients, and 2 of them ended up having cytokine reactivation syndrome. Fortunately, both of them were mild, and they responded very well to tocilizumab or Actemra. But we do have to keep that in mind about Novartis. And I'm a little bit nervous about it, by the way, because of those particular results. Other patients with other autoimmune diseases have been treated. Scleroderma is a related disease to lupus where it attacks the tissues of the body and causes hardening and scarring and fibrosis. We call it scleroderma. Sclero means thickening of, derma means skin because their skin gets very thick. But also, unfortunately, the same thing can happen in the lungs, the blood vessels of the body. Can be quite deadly. Well, this is a treatment that has no good treatments. There is no FDA approved drug for the systemic treatment of scleroderma. We just have one that's just for the lungs, but nothing else. Well, 3 patients with bad scleroderma were treated with the CD19. It was the same German group, by the way, the 8 patients with lupus that got the therapy in the German group. They also treated these 3 scleroderma patients the same way. They were much better after 6 months. Much better in that some of them actually were getting gangrene and sores on their fingertips, went completely away. So that was just really incredible because we just don't have any treatments like that for scleroderma. So I'm excited that for clinical trials to be done for that disease. Myositis is where the immune system attacks the muscles. So myo means muscle, itis means inflammation of. These patients, they get very weak in the shoulders, the thighs, but when it progresses, they can have problems with breathing, with swallowing, and it can be deadly. There's one particular type called antisynthetase syndrome that's incredibly hard to treat. Many patients do not respond to therapy at all. They used the CD19 in 3 patients. 2 of them went completely into remission at 6 months. One of them was at a year, and then there is another patient who they mentioned, but it's too early to tell. So that's just phenomenal. We just never had a therapy that where we could get patients into remission that quickly, and so many patients with severe myositis. Myasthenia gravis is another autoimmune disease where patients get weak. It can be very deadly in many patients. And so they treated 14 patients with a different type of CAR T cell therapy called Descartes 08. Now, you notice on this one, I put RNA CAR T. That's different because remember, with the other CAR T cell therapies, I talked about the virus inserting DNA. And that DNA inside of the CAR T cells, that's what makes those CAR T cells multiply inside of the patient's body. Well, the interesting thing about this RNA CAR T cell therapy is that the RNA CAR T cell, when it goes into the person's body, it just sticks around and it does its job, but at some point it dies. It doesn't multiply over and over again. So that's a big difference with this type of therapy. Well, this particular CAR T cell therapy targets BCMA. So remember, that's the one. So it basically kills the plasma cells, the plasmablasts, and the most mature B cells, but leaves all of the other B cells alone. And so that's just what they chose to target. But it worked. It did very good in these myasthenia gravis patients. Some other good things about this Descartes 08, they don't need any chemotherapy. So you don't have to give them the cyclophosphamide whatsoever. That's a big plus with this therapy. So there's possibly less infections in these patients. And none of the patients got the cytokine reactivation syndrome. And that's probably because we're not seeing those CAR T cells multiply inside of the body. And there was none of the severe neurological side effects that we can see with the other CAR T cell therapies. Well, all of the patients got much better. It's very hard to, I don't know of any therapy that does that good for myasthenia gravis. The downside, though, is that remember I told you that these CAR T cell therapies with RNA in them, they eventually die. They don't keep multiplying. And so at some point, the B cell system starts to make the bad B cells again, the autoreactive B cells, and we do see those autoantibodies for myasthenia gravis start to increase at the 9-month mark. And so they think that they're probably going to have to give these patients an infusion of CAR T cell therapy with the RNA type probably once a year or every 9 months. And by the way, the myasthenia gravis still was under very good control up to the 1-year mark where they were following them. So we don't know what happens after that. They're still researching these patients, but probably they're going to have recurrent therapy. But there are these pluses: no chemotherapy, no cytokine reactivation syndrome, no severe neurological side effects. And it has other pluses, which I'll mention in just a little bit. So what are other adverse effects that can occur with autoimmune diseases with this CAR T cell therapy? Well, we did see some in the myositis group. Remember, that's the severe anti-synthetase syndrome group. They got the same treatment as all the lupus patients, that German group that I mentioned that had no severe side effects. But all 3 of these patients developed cytokine reactivation syndrome. It wasn't severe. All of them were treated with Actemra or tocilizumab, and they all responded beautifully. They did very, very well. 2 of the 3 patients, unfortunately, developed the neurological side effects. They developed something called ataxia, which is a balance problem, but it went away after a week. My suspicion is probably because this is part of the neurological system. When we look at people with B cell cancers getting CAR T cell therapy and then they get the severe neurological problem, we think that it has to do with there being a problem with what we call the blood-brain barrier in keeping the bad CAR T cells out of the neurological system. So these patients may have something abnormal with their neurological system that may predispose them to getting these side effects. And by the way, that's why also that with the lupus studies, they're excluding patients who have severe neurological problems. So if you're a lupus patient and you're wondering if you can go into a clinical trial, if you have neurological disease, you're probably not going to be able to do so unless it's that part of the disease is completely in remission. Potential other long-term side effects: B cells are important for making those antibodies that recognize foreign invaders. We call them gamma globulins, is another name for them. When they become low, we call it hypogammaglobulinemia, and that can increase the risk of infection. So the question is, could infections happen over time? All of these patients have been studied for 3.5 years or less. So what happens at a decade, at 2 decades in these patients? And then the big question is, how about cancer? In November of last year, September the 28th, the FDA put out this black box warning for all of the FDA approved CAR T cell therapies in America. They stated, we have become aware of the risk of T cell malignancies or cancers with serious outcomes, including hospitalization and death following treatment with BCMA and CD19 directed genetically modified autologous T cell immunotherapies. I'll describe that last two lines there. So CD19, you already know that's the badge that we're targeting. Genetically modified, we're putting a DNA inside of those CAR T cells, so we're genetically modifying their DNA. Autologous means that the T cells that are being made into B cells are coming from the person themselves. Auto means self, and then immunotherapy, we're using immune system cells to treat patients. Basically, it's a fancy line for CAR T cell therapy. So, so why does this happen in the CAR T cell therapy patients? So let's go back to how we give CAR T cell therapy to patients. So we're giving them, first of all, we're giving them chemotherapy, cyclophosphamide and fludarabine. Both of those are associated with an increased risk of blood cell cancer. So we can't ignore that problem. So by the way, that's kind of something nice. If we could use a CAR T cell therapy that doesn't require chemotherapy like Descartes, that might be a good way to go. But this chemotherapy, remember, it gets rid of most of the white blood cells inside of the person's body. We give them that CAR T, we infuse them back with their CAR T cells, and then those CAR T cells multiply so that they can destroy all the B cells. But just think about it. What if one of those CAR T cells becomes rogue? Remember, these CAR T cells, they have that foreign DNA in them and they are multiplying. And any cell in the body that multiplies can potentially become cancerous. And what if it becomes cancerous? And that's what they're talking about. So far, the first FDA-approved drug for CAR T-cell therapy was in 2016, and since 2017, around 30,000 patients have been treated. So that's an incredibly high number of patients. Out of all of them, there's only been a few identified cases of this CAR T cell lymphoma. So it is rare when it does happen, but there have been at least a couple of patients in each of the FDA approved CAR T cell therapy. And so because of that, the FDA is calling this a class effect. But it's with the DNA type of CAR T cell therapy, the ones that insert DNA where they replicate throughout the body. So we cannot ignore this in our lupus patients, our scleroderma patients. If we get them into remission, and if they stay in remission for a couple of decades, what if they do get this CAR T cell lymphoma? What if it's a higher amount than we're seeing initially, where it's just rare and we don't know? It's going to take 10, 20, 30 years before we can answer that questions. Because, people with autoimmune diseases, even though unfortunately these diseases can be deadly, unfortunately, we do see patients die of them at a young age and early. Most of our patients live a long, normal lifespan. Do we want to expose them to the possibility of this cancer over that amount of time? And we really don't know how often it's going to happen. And then how about the long-term potential for infections? And then this CAR T cell cancer that we're seeing. And then we're just seeing side effects after just a few years of studies, but are there other side effects that we're not seeing that could appear decades from now? And the reason I'm mentioning all this, by the way, is that on the internet, it looks like these are miraculous cures for lupus, but we always have to think about the potential for side effects. And so, should CAR T cell therapies be restricted to those who that are unlikely to cause CAR T cell lymphoma? And that would be for example, the RNA type of CAR T cell therapy, like Descartes-08 that I had mentioned earlier, because Descartes-08 it doesn't multiply in the body, so probably it's not going to cause that CAR T cell therapy or that CAR T cell lymphoma. Very unlikely, probably not at all. And then also, we're not giving them chemotherapy. So that decreases their risk of cancer as well in those particular patients, because those RNA CAR T cells, they do eventually disappear. Now, there is a downside of this type of therapy, the Descartes-08, and I mentioned it earlier. With the other CAR T cell therapies, you give it once, and then there's no more treatment. Those patients who are still in remission with their lupus, they got one treatment and that's it. It's still working up to 3.5 years later. But with Descartes-08, with this RNA type of CAR T cell, treatments probably have to be repeated. Is it every 9 months? Is it every year? We don't know. So far, we just have the myasthenia gravis data, but it could be different in lupus patients. Maybe lupus patients, maybe their antibodies will start to become more active earlier after treatment. Maybe it'll be later. Maybe it'll be a couple of years before we see them come back, and we don't know. The clinical trials are just now starting. So, one question that some of you might have, because unfortunately, I know that some of you have severe systemic lupus that's not under control. You've failed multiple therapies, unfortunately. Even though I can get most of my patients into remission and most of my patients are in remission, some of them, they just don't respond to all the therapies that we have. So we do need to do research to find better therapies. If you go to my website, lupusencyclopedia.com, this is the actual website where I describe CAR T cell therapy. I simplify it very well. It goes into a lot more detail than I did in this talk. But at the very bottom of the page, I list all of the clinical trials that are currently going on. It also includes the contact information. If you just go to lupusencyclopedia.com and do a search for CAR T, you'll find it there. But please only consider this if you have severe uncontrolled lupus and that you have failed multiple, if not all, of the other therapies. Then you might want to think about some of these CAR T cell therapies. Do you really want to expose your risk for CAR T cell lymphoma, for example? Even though it's been incredibly rare, should you consider some other CAR T cell therapies like the Descartes-08? Just some things to think about. So, what is the future with CAR T cell therapy and lupus and other autoimmune diseases? Number one, we need much larger studies. And will they reproduce the results of these smaller studies that were done? There are clinical trials that are being started. And then these remissions, how long do they truly last? We don't know. We'll have to keep following these patients over time. And could there be side effects we haven't seen so far, especially those long-term side effects? And then we have to ask the question, which CAR T cell therapy is better for which patient? Like that patient with the anti-SSA antibody. Interesting. You'll read on my website about this interesting one that they did at Johns Hopkins, where they developed this type of CAR T cell therapy. It's a little bit different. It's called CAART, but it actually identifies one type of B cell that makes one type of autoantibody, and that one, it was an antiphospholipid antibody. But just think, the patient who only has one type of autoantibody, like that anti-SSA antibody, maybe that's a better type of therapy to give. And then what about the other autoimmune diseases? Which is going to be best for them, and does it work? I suspect in Sjogren's syndrome, or Sjogren's disease, it probably is going to work. Sjogren's is a B cell driven disease. It's due to, when you do a biopsy of infected organs, it's just full of B cells. So it just makes sense. It probably would work. But I have concerns. Remember, the higher the B cell load, the higher the risk of side effects like cytokine reactivation syndrome. And Sjogren's disease patients have a high B cell load. So we probably want to use CAR T cell therapies that don't cause cytokine reactivation syndrome. Could something like Descartes-08 be a better option? And probably only our sickest patients should get CAR T cell therapy. If we're going to expose them with possible side effects that we don't know about, we want to make sure we do it in someone who's really has truly failed everything out. And should we only use CAR T cell therapies that will not cause CAR T cell lymphoma? That's a question I would ask as a patient if I was entering a research study. And then, if proven safe and effective, the big question is, how about even mild systemic lupus? Now, this is just a dream of mine, by the way, but just think about it. If we found a CAR T cell therapy that was incredibly safe, that did not cause any of these bad side effects, and the patient had a long term drug free remission, it could be worth it. CAR T cell therapy is incredibly expensive, around $100,000. But just think over the lifespan of a patient with even mild systemic lupus, it's well more than $100,000. So I would like to dream, but it's still too premature. So remember that Chinese patient I mentioned earlier? Well, the first two patients, they're still doing well. Over 3.5 years of remission, not on any drugs. The Chinese group reported their results at our November meeting. No major side effects whatsoever. So let's dream big. Let's hope that there is potentially a future for these therapies as long as we find the safest ones. And I hope that we can find better therapies and get all of you into remission and not have to keep you on drugs for the rest of your life. So thank you very much, and I'm open to answering any questions that you might have.
Great. Thank you so much, Dr. Thomas. That was such an awesome deep dive. We do have several questions. So a lot of these that you answered in your talk already, but one of them from Patty is, when do you estimate something like this might eventually be available for lupus patients to get from like a rheumatology office outside of a trial? What is the timeline usually for something like that?
Yeah, so the data is already being reported just about a year after the Novartis trial became available. So it does take probably 2 to 3 years to get all the data, plus and get enough patients into the study. So I would envision that they showed great results and no major side effects, like the Descartes-08 is just winding up, and we don't see those bad side effects like I mentioned with the other studies. Could we have that available in 5 years inside of the office? That's a possibility. I actually have a severe lupus patient who I'm possibly going to enter. There's a doctor in Bethesda, Maryland, not too far from me, who does it in his office as part of the research study. But I can possibly get that for her with compassionate use through the FDA. So actually, you can get it right now through the FDA with compassionate use, even if you're not don't satisfy the inclusion and exclusion criteria for a study. So it already is trickling as far as becoming available for even for clinicians like myself. And hopefully, maybe in 5 years, if these studies show to be true, maybe it'll become a treatment in lupus patients.
Wow, that's so exciting. Another question that we have is, how long is the infusion typically during the trials for lupus patients, and how many infusions over what period of time typically?
Yeah, sure. And almost all the CAR T cell therapies that I just mentioned, they just get one infusion, and it's the fludarabine and the cyclophosphamide. It's not real high dose like we use for cancer and stuff, but it's enough to lower the white blood cell count. So it's just that one infusion, and I'm not sure how many minutes that it actually lasts. Now the Descartes-08 is different. The Descartes-08 is actually a weekly infusion 6 times in a row. And remember, that's the one that uses RNA instead of DNA. So it doesn't
Yeah,
replicate in the body. And so that's why we have to give them a bunch of infusions in order to give them enough of these CAR T cells to kill their B cells. And then
noted. Okay.
the question is, do we have to repeat that, every year? And will one infusion repeated every year be enough, or do we have to do the 6 infusions? They're still trying to figure that out.
Okay. Makes sense. One of the other questions that we have here is about the comment that you made about neurological symptoms in lupus potentially not really being a fit because of the side effects with this therapy. If someone has lupus headaches or lupus cerebritis or anything like that, would you consider that to be someone with neurological issues with lupus who maybe would not be a good trial candidate at this time?
With the cerebritis, absolutely, because one of the theories is that these CAR T cells might get into the brain because of a disruption of what we call the blood-brain barrier. The blood-brain barrier is protective for the brain and the spinal cord. It keeps out all the bad stuff. But people who have inflammation of the brain and spinal cord and nerves from their lupus, that can potentially increase that risk of severe neurological disease. So the cerebritis, myelitis, optic neuritis, severe peripheral neuropathy, I would not, are probably not even going to be allowed in the studies at this particular point. Now, headaches, most of the headaches that we see in lupus patients are migraine and tension headaches, and those would not be counted as neurological lupus neurological problems. But if the doctor thinks that the patient has an actual lupus headache that gets much, much better with treatment, then gets worse during lupus flares, that patient should not get these therapies yet.
Okay, perfect. And
Except the
then,
Descartes-08 is a possibility because it
yeah,
doesn't cause it.
yeah. Um,
By the way, I do not have stock, or I'm not a part of the company, or I just got to throw that out there. But it's just very interesting how it works so differently.
yeah. Um, we understand that. The other question that we have here, actually, two people asked this question. You kind of addressed this already a little bit with the other medications for lupus, but does somebody need to stay on their prednisone or Benlysta while they're doing a CAR T trial? Are there situations where that would be the case?
Yeah, and thanks so much for asking that, because I should have mentioned that in my talk. So you saw that the graphs where I showed you where they got the CAR T cell therapy. Well, they stopped all of their therapies very soon before that. So
Oh,
they're
okay.
on none other immunologic therapies whatsoever once they get that CAR T cell therapy. And I forget exactly how many days before the infusion, but they do stop everything.
Oh,
Now,
wow. Okay.
by the way, the prednisone or the steroids, I suspect that they do it slowly in patients who have adrenal insufficiency, but otherwise they try to stop everything.
Okay. Perfect. I'm just checking to see. I think that actually concludes our questions, given that you answered so many of them during the talk. Thank you so much for joining us today. This was such an amazing deep dive into the details of all the existing trials to date, and there was so much information. So for everybody who joined us today, just so you know, this replay will be accessible here on Lupus LA's Facebook page, and we'll also have it available on our YouTube channel to follow. So you can go back and reabsorb anything that you missed during the presentation, because there was so much information. And if you want to learn more about Dr. Thomas, his practice, his books, and even the trials that he discussed, we linked to his website in the caption of the post. So you'll be able to access that information there as well. So thank you so much, Dr. Thomas. If there's anything else that we should know before you leave, let us know. But otherwise, thank you so much for your time today.
Well, remember, everybody, knowledge truly is power. My patients who learn as much as they can about their lupus, they're the ones who do the best in the long run. So you're taking that important step. So good luck with your lupus, and I hope everybody does well in life and health. Bye. So it all started in 2016. In 2016, a